Finger drop is a condition where a person cannot extend their fingers at the main finger joints, even though the finger flexors and wrist muscles still work. This means the hand can't open up fully, making daily tasks difficult. While wrist drop and foot drop are more commonly recognized, finger drop is less understood and often overlooked. The inability to extend the fingers can be partial, affecting just a few digits, or global, involving all five. Understanding finger drop starts with knowing how the finger extensor muscles and nerves work together, and why their malfunction leads to this unique problem. Finger extension is controlled by a group of muscles in the forearm, mainly the extensor digitorum communis. This muscle originates from the lateral epicondyle of the humerus and sends tendons to each finger. Additional muscles like the extensor digiti minimi and extensor indicis help extend the small and index fingers. The thumb has its own extensor muscles. All these muscles are supplied by the posterior interosseous nerve pin, a branch of the radial nerve. When any part of this system is disrupted, finger drop can occur. Understanding this anatomy is crucial for pinpointing the cause of finger drop. Finger drop can be classified as either global or partial. Global finger drop means all five fingers are affected, while partial finger drop involves just 1 to 4 digits. The pattern of weakness can give important clues about the underlying cause. For example, global finger drop often points to a problem with the pin, while partial finger drop may suggest issues with specific nerve roots or tendon injuries. Recognizing these patterns helps clinicians narrow down the diagnosis and choose the right tests for further evaluation. Most frequent cause of finger drop is posterior interosseous nerve pin neuropathy. This nerve can be injured or compressed as it travels through the forearm, especially near the elbow. Pin neuropathy often results in global finger drop, affecting all digits. Causes include trauma, entrapment at the arcade of Fros, or compression by masses like ganglion cysts. Sometimes the nerve is damaged during surgeries or by repetitive strain. Recognizing pin neuropathy is key, as it guides both diagnosis and treatment. Cervical radiculopathy, especially involving the C7 and C8 nerve roots, is another important cause of finger drop. This condition arises when nerves in the neck are compressed or irritated, often due to degenerative changes or herniated discs. Unlike pin neuropathy, cervical radiculopathy usually leads to partial finger drop, affecting specific fingers. Patients may also experience neck pain, numbness, or weakness in other parts of the arm. Identifying this cause is crucial, as it may require different treatments, including surgery. Parsonage-Turner syndrome, PTS, is a rare but significant cause of finger drop. It often follows events like infections, vaccinations, or surgery. PTS is characterized by sudden severe shoulder or arm pain followed by muscle weakness and sometimes finger drop. In this study, PTS accounted for about a third of finger drop cases. Most patients had an identifiable trigger, and the left side was more commonly affected. Recognizing PTS is important because it can mimic other nerve injuries but may have a different prognosis and management. Trauma to the forearm or surgical procedures can also lead to finger drop. Injuries may directly damage the pin or the extensor tendons. Iatrogenic injuries, meaning those caused by medical interventions, are not uncommon. For example, surgeries like biceps tendon repair or the creation of dialysis access can inadvertently harm the pin. In this study, iatrogenic and traumatic causes together accounted for over a quarter of finger drop cases. Careful surgical technique and awareness of nerve anatomy are essential to prevent these complications. Not all finger drop is due to nerve problems. Rupture of the extensor tendons, especially in conditions like rheumatoid arthritis, can also cause partial finger drop. In these cases, the nerve conduction studies are normal, but the fingers still cannot extend. Recognizing non-neural causes is important because the treatment approach is different, often involving surgical repair of the tendons rather than nerve-focused therapies. Some patients, no clear cause for finger drop can be found, and these cases are labeled idiopathic. Rare causes include conditions like Guillain-Barré syndrome, multifocal motor neuropathy, amyotrophic lateral sclerosis, and even infections or tumors. Although less common, these possibilities should be considered, especially when the typical causes are ruled out. A thorough evaluation helps ensure that rare but serious conditions are not missed. Detailed neurological examination is the cornerstone of diagnosing finger drop. Clinicians assess which fingers are affected, the strength of the extensors and flexors, and look for associated symptoms like pain or numbness. Determining whether the drop is partial or global can provide immediate clues about the likely cause. This step guides further testing and helps avoid unnecessary procedures. Electrodiagnostic studies, including nerve conduction and electromyography (EMG), are vital in evaluating finger drop. These tests help distinguish between nerve and tendon causes, assess the severity of nerve injury, and localize the lesion. For example, EDX can reveal whether there is axon loss, demyelination, or conduction block. Serial studies can also monitor recovery over time, making them an essential tool in both diagnosis and follow-up. Ultrasound US is a valuable, accessible, and cost-effective imaging tool for finger drop. It can visualize the radial nerve and its branches, detect enlarged fascicles, and identify compressive lesions like cysts or tumors. US is especially useful for spotting changes in nerve structure, such as hypoechoic or hyperechoic patterns, and for detecting neuromas. In some cases, US findings can directly influence the choice of treatment, such as surgical decompression. Magnetic resonance imaging (MRI) is sometimes used to further evaluate finger drop, especially when cervical radiculopathy or muscle tendon injuries are suspected. MRI provides detailed images of soft tissues, nerves, and the spinal cord. While more expensive and less readily available than ultrasound, MRI can be crucial for complex cases or when surgical planning is needed. An illustrative case involved a patient with rheumatoid arthritis who developed partial finger drop in the 4th and 5th digits. Examination revealed swelling and subluxation of the ulnar head, and imaging confirmed ruptured extensor tendons. This pattern, known as Vaughan-Jackson syndrome, highlights how joint disease can lead to tendon rupture and finger drop. Recognizing this scenario ensures that patients receive the correct surgical intervention rather than unnecessary nerve treatment. Another case featured a patient with global finger drop caused by compression of the pin by ganglion cyst. Ultrasound revealed the cyst pressing on the nerve, and surgery confirmed the diagnosis. After removal of the cyst and nerve decompression, the patient's symptoms improved. This case demonstrates the importance of imaging in identifying treatable causes of nerve compression. Third example involved a patient with partial finger drop affecting the ulnar 3 digits. MRI of the cervical spine showed spondylosis and foraminal stenosis at C6, 7, compressing the nerve roots. This case illustrates how neck problems can manifest as hand weakness and why imaging beyond the forearm is sometimes necessary for diagnosis. Iatrogenic injuries to the pin are a significant cause of finger drop, especially after procedures like biceps tendon repair or creation of dialysis access. In these cases, EDX studies often show total or partial axon loss, and ultrasound may reveal enlarged or abnormal fascicles. Prevention through careful surgical planning and nerve identification is crucial, but prompt recognition and management can improve outcomes if injury occurs. Pattern of finger drop, whether global or partial, offers valuable diagnostic clues. Global finger drop strongly suggests pin neuropathy, while partial finger drop is more often seen with cervical radiculopathy or tendon rupture. By carefully analyzing which fingers are affected and correlating with clinical history, clinicians can narrow down the list of possible causes and select the most appropriate tests. In patients with Parsonage-Turner syndrome, EDX studies often reveal partial axon loss, conduction block, or total axon loss in the pin. These findings help confirm the diagnosis and assess the severity of nerve involvement. Ultrasound may show enlarged fascicles, but not always. Recognizing these patterns is important for prognosis and planning rehabilitation. For iatrogenic injuries, EDX studies can show a range of findings, from total axon loss to demyelination or conduction block. Ultrasound often reveals structural changes in the nerve, such as enlargement or abnormal echogenicity. These findings not only confirm the diagnosis but also help guide decisions about surgical repair or conservative management. Ultrasound findings in finger drop can include enlarged nerve fascicles, hypoechoic or hyperechoic changes, and even neuromas. In some cases, US can detect compressive lesions like cysts that are not visible on other tests. These observations are especially helpful in planning surgery or other interventions, making ultrasound a valuable tool in the diagnostic process. Treatment for finger drop depends on the underlying cause. Conservative therapy may include rest, nonsteroidal anti-inflammatory drugs, and steroid injections. These approaches are often tried first, especially when the cause is unclear or when nerve recovery is expected. Physical therapy can also help maintain hand function and prevent stiffness while the underlying issue is addressed. Surgery may be needed for finger drop caused by nerve entrapment, compression, or tendon rupture. Procedures can include nerve decompression, removal of compressive lesions, or tendon repair. In some cases, early surgical intervention leads to better outcomes, especially if performed within a few months of injury. Surgical planning is guided by imaging and electrodiagnostic findings. The outlook for finger drop varies depending on the cause and severity. Some patients recover fully with conservative treatment, while others may need surgery or long-term rehabilitation. Early diagnosis and appropriate management are key to improving outcomes. Serial EDX studies and follow-up imaging can help track recovery and guide adjustments in therapy. Preventing finger drop involves awareness of risk factors, careful surgical technique, and early recognition of symptoms. Surgeons and clinicians should be familiar with the anatomy of the pin and the potential for injury during procedures. Patients with underlying conditions like rheumatoid arthritis should be monitored for tendon problems. Education and vigilance can reduce the incidence of this disabling condition. Study stands out for its large cohort of 87 patients and the comprehensive use of both electrodiagnostic and ultrasound evaluations. By analyzing a wide range of causes and correlating clinical patterns with diagnostic findings, the research provides valuable insights into the diagnosis and management of finger drop. The inclusion of detailed case examples further enhances its practical relevance for clinicians. Despite its strengths, the study has some limitations, including its retrospective design and lack of long-term follow-up for many patients. Future research could focus on prospective studies, long-term outcomes, and the development of standardized protocols for diagnosis and management. Continued innovation in imaging and electrodiagnostic techniques will further enhance our understanding of finger drop. Clinicians should remember that pin neuropathy is the most common cause of finger drop, but other conditions like cervical radiculopathy and tendon rupture are also important. The pattern of finger involvement provides crucial diagnostic clues. Electrodiagnostic and ultrasound studies are complementary tools that help distinguish between neural and non-neural causes, guiding effective treatment. For patients, finger drop can be a frustrating and disabling condition, affecting daily activities like writing, typing, or gripping objects. Early recognition and prompt medical attention can make a significant difference in recovery. Patients should communicate any new weakness or changes in hand function to their healthcare provider, as timely intervention can improve outcomes. In summary, finger drop is a complex condition with multiple potential causes, most commonly pin neuropathy. Careful clinical evaluation supported by electrodiagnostic and ultrasound studies is essential for accurate diagnosis and effective treatment. Recognizing the patterns of finger involvement and understanding the underlying anatomy can help clinicians provide the best care for their patients. Ongoing research and education will continue to improve outcomes for those affected by finger drop.